Yes, I'm honored to be invited to this wonderful conference. And Mr. Chairperson, thank you for the kind introduction. And today I'll be talking about the prevention of major infection following heart transplantation. And I'd like to share the findings of a survey conducted last year by the Korean Society for Transplantation. It focused on infection prevention protocols in major transplant centers across Korea. Let's start with the antibacterial prophylaxis. This data comes from an analysis of 239 patients who experienced in-hospital infections. The most common infections were pneumonia, followed by urinary tract infections and bacteremia. Rates of mediastinitis were 3.8%, and surgical site infections were 2.1%. And risk factors for in-hospital infections included ventilator care, excessive bleeding, and graft failure. The primary goal of antibacterial prophylaxis is to prevent surgical site infection. However, there is limited direct research on this topic. Therefore, the latest guidelines from the American Society of Transplantation rely on general cardiac surgery studies for their recommendations. They suggest using first-generation cephalosporin for 24 hours or adding vancomycin in cases of MRSA carrier. But in real practice, many centers tend to be more aggressive with antibacterial prophylaxis. According to the survey conducted by the Korean Society for Transplantation, approximately 50% of heart transplant centers use a combination of ceftazidime with vancomycin or teicoplanin for a duration ranging from 2 to 7 days. The next topic is antiviral prophylaxis. One of the most crucial viruses post-organ transplant is cytomegalovirus. To determine the preventive measures for CMV, it is essential to understand the CMV seroprevalence in the country's population. In Korean adults, according to test results conducted in blood donors or hospital employees, approximately 95 to 98% are CMV seropositive. So in Korean adults, CMV infections post-organ transplant are primarily reactivated infections. In infected patients, some develop symptomatic CMV disease, which can manifest as CMV syndrome with systemic symptoms or tissue-invasive disease localized in specific organ. The primary goal of antiviral prophylaxis is to prevent CMV disease. The first method is prophylaxis. It involves administering antiviral medication for a specific period to all transplant patients, and the second method is preemptive therapy. Regular blood tests for CMV are conducted, and if the levels exceed a certain threshold, even in the absence of symptoms, preemptive therapy initiated. International guidelines recommend prophylaxis for CMV donor-positive recipient-negative cases or lung transplants. And for CMV recipient-positive kidney, liver, heart transplants, both options are equally recommended. So centers can choose between prophylaxis and preemptive therapy based on their specific situations. CMV might indirectly affect graft rejection due to its immune modulating effect. However, the impact might differ in countries like Korea, where the majority are CMV seropositive. Studies in Germany with R-positive individuals did not show significant differences in rejection or graft loss. In heart transplant cases, another factor to consider is vasculopathy. An Italian group measured the lumen size of LAD using IVUs in 29 heart transplant patients at 1 month and 12 months post-transplant. The results showed a significant narrowing of the lumen in CMV-infected patients. Spanish data indicated that vasculopathy occurred in 6.6% at first year, 23% after 5 years, and over 50% after 10 years. But not all cases were directly linked to CMV. Other risk factors influenced long-term vasculopathy. Our hospital data indicated that factors like age, ischemic time, renal replacement therapy, and triglyceride levels posed risks, but CMV was not a significant risk. Looking at these study results, it suggests there might be a link with CMV in the first year, but in the long term, after that first year, other common risk factors seems to be more important. Considering this point, guidelines suggest a prophylactic period of 3 to 6 months for CMV positive or negative cases and recommend both prophylaxis and preemptive therapy with equal intensity for our positive heart transplant patient. The survey from the Korean Society revealed that regardless of the organ type, most transplant centers applied prophylaxis in the positive or negative cases, and in our positive cases, 65 to 75% centers applied preemptive therapy with monitoring period ranging from 3 to 12 months post-transplant. Allow me to introduce our hospital protocol consistent since 1999. We employ a hybrid strategy utilizing prophylaxis for the first month and then transitioning to preemptive therapy until the 12-month post-transplant. We start preemptive therapy when CMV antigenemia monitoring shows 100 or more positive WBCs. However, using 100 as the threshold led to several cases of secondary CMV retinitis, especially if they missed our patient follow-ups and the count sharply increased by the next visit. So, consequently, we lowered the threshold to 50 cells. In our hospital, we apply 50 as the starting threshold for a preemptive therapy in all organs. Our hospital's instance of CMV disease is 4% in kidney, 10% in lung, and 11% in heart transplants. This disparity is likely due to the strong immunosuppression in lung and heart transplantation. Lastly, it's important to note that CMV antigenemia assay are labor-intensive and time-consuming. Fortunately, in July 2016, Korean National Insurance started covering quantitative real-time CMV PCR, prompting a shift in our testing methods. During the transition to a new testing method, we conducted an internal validation study by performing 2 tests simultaneously on the same samples. As a result, 50 CMV antigenemia cells corresponded to 10,000 copies in quantitative PCR. So currently, we initiate preemptive therapy based on this threshold. Let's shift our focus to antifungal prophylaxis. This is the survey from the Korean Society. In heart transplant, 63% of centers administer antifungal prophylaxis for 1 month. Nystatin is the most commonly used agent intended for selective decontamination of GI tract. However, the studies on the use of a non-absorbable agent like nystatin for prophylaxis have shown inconsistent results, leading to its non-recommendation in the recent guidelines. The purpose of this antifungal prophylaxis is to prevent candida infections. According to recent international guidelines, routine candida prophylaxis is not recommended for heart and kidney transplantation. However, in cases such as long-term ICU care, prolonged use of broad-spectrum antibiotics, or the use of ECMO, LVAD, antifungal agent of echinocandin class can be used to prevent early candidemia. There's an exception in lung transplant where all patients are prescribed antifungals for 6 months. In this scenario, the purpose is to prevent invasive aspergillosis, not candidiasis. For liver or heart transplant patients, high-risk groups might require antifungal prophylaxis to prevent aspergillosis. However, the specific risk factors are not yet well understood. Now, let's talk about the screening and treatment for latent tuberculosis. In cases where an old tip lesion appears in a simple chest X-ray but has not been properly treated, or if the tuberculin skin test recently turns positive, or if there's a family member with active tuberculosis, a diagnosis of latent tuberculosis infections can be made without additional test. If these clinical risk factors are absent, additional screening is necessary. While the tuberculin skin test has been widely used for a long time, it often gives false positive or negative results. So specific tests targeting Mycobacterium tuberculosis, like the interferon gamma release assay, is preferred nowadays. According to a survey of Korean society, most centers, regardless of the organ type, primarily use IGRA test for the screening. The treatment for latent tuberculosis can be completed in 3 to 4 months if rifampin is included. However, due to interaction between rifampin and immunosuppressive agents, isoniazid therapy for 9 months is more common post-transplant. In our hospital's experience with kidney transplant patients, those with positive tuberculin skin test were treated, and those with negative test were not treated. As a result, there were no cases of tuberculosis in the treated group, while the 4 patients occurred in the untreated group. Overall, the incidence rate was 1.3%. In the past, when no measures were taken, tuberculosis occurred in 4% of kidney transplant patients. Simply by introducing the tuberculin skin test, the occurrence of tuberculosis decreased from 4% to 1.3%. Nowadays, the IGRA is being used, and the tuberculosis incidence rate has been maintained at less than 1%. Looking at our liver transplant patient, they were not treated for latent tuberculosis due to concerns about the hepatotoxicity of anti-TB medications. Tuberculosis occurred in 2% of patients post-transplant and around 9 months after liver transplant. Starting from March 2020, our hospital began screening all liver transplant patients for latent tuberculosis. About 23% were diagnosed, and among them, 86% received treatment, while 17% of treated patients had to stop early due to various side effects. Hepatotoxicity concerns only account for 38%. Previously, without any intervention, tuberculosis occurred in 2%, but with LTBI screening, it decreased to about 0.5%. Yeah, so far we have covered antibacterial, viral, fungal prophylaxis, and LTBI treatment after heart transplantation. It's important to know that there's no one-size-fits-all approach because different immunosuppressive protocols, available tests, or infection prevention protocols at each centers. Infection prevention after organ transplant is a tailored process, and collaboration between transplant team and ID specialist is crucial. That concludes my talking. Thank you for your attention.